Hi, good morning everyone. My name is Julianne and I welcome you here today for this very meaningful panel discussion on the breast cancer journey in Singapore, jointly organized by the Singapore Cancer Society, National University Cancer Institute, Singapore Breast Cancer Foundation, National Cancer Centre Singapore, Tan Tock Seng Hospital, as well as the Health Promotion Board. We will be taking questions at the end, so please put them in the Q&A or comment section and we'll answer them during the end of the webinar. We will also be sharing the key information and useful links in the chat box, so do keep a lookout for it. Okay, so we are now in we are now in October, which is the National Breast Cancer Awareness Month. And today we will be going through the various aspects of the breast cancer journey in Singapore, from risk to screening, diagnosis, treatment, rehabilitation, and community support. According to the latest Singapore Cancer Registry Annual Report 2021, on average, there are about 7 breast cancer diagnoses every day. And it is crucial for women to understand their risk and learn about how they can win in the fight against breast cancer. Today, we are bringing together 4 panelists. From the breast cancer community, Dr. Celene Ng, Dr. Chia Yee Hong, Dr. Amanda Liew, and Ms. Ng Xin Yi. So before I begin, my name is Julianne again, and I'd like to share something, but please do not be like me. Let's take a look. I felt like my life at that point when I was diagnosed, the bricks were slammed and I was ejected out of my career in everything that I was doing. When I was first diagnosed, I was really at the peak of my career. So on that very fateful day, right, I looked into the mirror and I was quite surprised that I actually saw something on the inner uppermost of my chest. And I thought, well, maybe that's something that's there and it will go away. And it did. When I noticed it to be slightly bigger, I quickly went to the breast surgeon the next day. So I went through a series of tests. She then, told me, unfortunately, unexpectedly at this age, that you have got breast cancer. And remember on that day, feeling like nothing else mattered.
On the day of diagnosis, I was with her and the breast doctor gave her the news. I was really, really heartbroken. I said, how can it happen to my daughter? So I tried to stay firm because I don't want her to feel sad. So I was really, really devastated. But on the other hand, I told myself, I must cheer her up. I must walk through the whole route with her. I cannot leave her alone. I'm glad she looked at everything very positive.
I think my mom is definitely a very strong factor in influencing my identity. She reminds me that beauty is, something that is only temporary, and the real beauty is in my heart. So my perception of health screening before I was diagnosed is, if I do not see anything or if I do not know anything, then I do not want to know. So yes, the health screening part is very much a conversation that my mom has with us. It's never the other way around. And she's an advocate, to do health screening and to make sure that one has that responsibility.
My mom, especially, she has all kinds of illnesses. So from that day onwards, I tell myself, I have to look after my own body in order to take good care of my children.
I am beginning to see that it is very important to really know my own health. Right, everyone. So a reminder, please do not be like me. If you do not see anything, still go and get yourself checked. So that's why we are here today. So I'm a cancer survivor and was diagnosed with stage 3 breast cancer in my 30s. It was a type called triple negative breast cancer, where I had a 12-month treatment surgery with the first 6 months of chemotherapy, and also followed by operation of mastectomy with a reconstruction of Diab flap from my abdomen. So that's the operation part, and then followed by 25 sessions of radiotherapy and 6 months of oral chemotherapy. Prior to being diagnosed, I led a career-driven lifestyle, maybe many of you can relate to. Exercise 3 times a week and ate clean. I was a former change and transformation head in a global private bank and ex-private banker. But more recently, post my cancer treatment, I made a complete life change and career switch, and I'm now a host and speaker on personal transformation through self-discovery. The anchor to my everyday now is fitness and living a healthy, active, and fitness lifestyle. Well, I will also share bits of my story through the chats today and have documented most of my journey on my social media. But for today, it is my honor to be joined by medical professionals here today, and I'm very passionate to join these special people with me today, that we can bridge this gap that cancer can be cured, and it can happen to any one of us if we did our best to take care of, even if we did our best to take care of ourselves. That is why we must know our own health data and empower ourselves. And even if we know someone who is diagnosed, our lives can be turned around with the angels, like these doctors and medical professionals who will take care of us and our loved ones along the way. So for our first panelists, we have Dr. Chia Yee Hong, who is a senior consultant and medical oncologist with the Department of Medical Oncology at Tock Seng Hospital. She completed her oncology fellowship in the United States of America and is a board certified by the American Board of Internal Medicine in Medical Oncology. Her main interests include breast cancer and quality improvement. Next, we have Assistant Professor Celene Ng, who is a consultant at the Department of General Surgery, Division of Breast Surgery at the National University Hospital. She is a trained oncoplastic breast surgeon with a subspecialty interest in young breast cancer and primary prevention. Her passion is to enable and equip women to care for their health by changing the public perception of breast cancer. So we'll hear a little bit more from you later. Also with us, we have Dr. Amanda Liew, Associate Consultant at the Division of Oncologic Imaging and the National Cancer Centre, Singapore. Dr. Amanda graduated from University of Edinburgh with honours and is currently a core faculty member for the Seng Health Diagnostic Radiology Residency Program in Singapore. Her special interest is in breast imaging, breast cancer research and education. Last but not least, we have Ms. Ng Xin Yi, Senior Physiotherapist from Singapore Cancer Society Rehabilitation Centre, She works closely with cancer patients, majority being breast cancer patients, by helping them to manage the side effects after their cancer treatments. This is achieved through customized treatments and education which aims to improve their quality of life. All right, so let's start with Dr. Celene. As we kickstart this conversation on breast cancer, can you share with us exactly how prevalent is breast cancer in Singapore?
So breast cancer is the commonest cancer affecting females in Singapore. To put this in context, I would like all of you who's tuning in here today to think about 12 other women in your life. It could be your sister, your mother, your grandmother, your colleagues, teachers, even the coffee auntie in the pantry or at your local kopitiam. If you know 12 other females, statistically, unfortunately, one of you will develop breast cancer. Breast cancer accounts for approximately 30% of all cancers diagnosed in females in Singapore. You may then say, well, even though it's so common, it's been around for ages, and I don't personally know anybody who's been affected by breast cancer. Well, the fact is, it concerns all of us and our generation. And it's a huge problem now, mainly because the incidence has been increasing over the past 2 to 3 decades by at least 3 times. So I'm glad that we have this session now so that we can focus on breast cancer awareness and preventing cancer and diagnosing it at an early stage.
How apt is that? Because of my personal experience, I do know that breast cancer can hit women from across a wide range of age group. Dr. Chia, can you share with us on the risk factors of breast cancer and which group of women is more prone to it?
Okay, so the most obvious risk factor for having breast cancer is being a woman and having breasts. Having said that, breast cancer, even though it's uncommon in men, there are men who develop breast cancer. So while we promote breast cancer awareness in women, we should also be looking at our male counterparts and family members. And if they do have a breast lump, it's not something to be ignored either, because men do get breast cancer. Typically, the men who get breast cancer may have genetic predispositions to getting breast cancer, such as the BRCA1 and BRCA2 mutations. So in terms of who gets breast cancer, a family history of breast cancer, especially if you have first-degree relatives affected, such as your mother, your sister, people who are very close to you genetically, that increases the risk of developing breast cancer. The risk is almost twofold if you have one affected first-degree relative, and threefold if you have 2 affected first-degree relative. The age at which your first-degree relative developed cancer was also important. So if they were pretty young, so if you had a sister who developed breast cancer at the age of 25, then it's a bit different if you had your mother develop breast cancer at the age of 80. So the risk of breast cancer also increases with age. Women here, as Dr. Celene said earlier, have a 1 in 13 chance of developing breast cancer. There are certain risk factors for breast cancer that are also beyond our control, such as early menarche, having your periods early, late menopause, going through menopause late, ethnicity, so Singaporean Chinese have a higher incidence of breast cancer compared to their Malay or Indian counterparts, and also having a history of benign breast disease. Nulliparity, meaning not having children, or late childbearing, first child after the age of 35, are also risk factors for breast cancer. Some of those things are not things you can change, but there are other things that we can. So lifestyle and medications also affect the risk of breast cancer. The breast cancer incidence rate in Singapore has really tripled in the last few decades. There's also a strong birth cohort effect, meaning that the younger people who perhaps when society becomes richer and more affluent, they adopt a more Western lifestyle. Their consumption of foods that are high in animal fat, red meat, and alcohol has gone up. And we see that as society adopts this Western lifestyle, that the breast cancer rates are going up. Obesity and sedentary lifestyle are also risk factors for breast cancer. And some women also may have received hormone replacement therapy after menopause to control their menopausal-type symptoms. And such therapies may also be risk factors for breast cancer. So when I talk to patients about hormonal therapy, which we do use to treat breast cancer, they start thinking about hormone replacement therapy. Those things are not quite the same. So the hormone therapy used in breast cancer is actually to sort of lower the female sex hormone levels in the body or to block the interaction between female sex hormones and receptors on cancer cells, whereas hormone replacement therapy is actually giving people hormones to replace the female sex hormone. So there's a difference there, but we often when we talk to patients about hormone replacement, about hormonal therapy, they confuse that hormone replacement therapy. Okay, so just wanted to make that clear.
You know, what you said, Dr. Chia, was very, very informative. But what really caught my attention was sedentary lifestyle. Well, that is on the one hand, a case for me, because I was practically at my laptop all the time. But the other thing was, my mom said earlier, she said that her mother, which is my grandmother, actually had different kinds of diseases. So what really caught me was actually thinking that perhaps maybe I should go for a genetic test, which is something that I did, and I got my results. So I'd like for you to actually share a little bit more, Dr. Chia, what it could be like for someone who actually takes a genetic screening.
So in Singapore, the provision of clinical genetic testing is actually tightly regulated by the Ministry of Health. So it's not something that you can go to a GP and get the test. So in particular, the ordering and interpretation of tests that are predominantly aimed at uncovering hereditary cancer syndromes is restricted to trained personnel, even in the restructured hospital. So I personally am not actually accredited to provide this particular service, although it is provided by my colleagues at Tock Seng. So usually for us, we, as medical oncologists, the patients who come to us are not people with just a family history. They are people who already have cancer. So the cancer genetics testing services are offered in all the 3 public clusters. Prior to testing, the prospective clients actually do have to go through a counseling session with professionals who are trained, and they would talk about the family history, the probability of finding something, the pros and cons of testing, and also the potential implications of testing, which can encompass their financial implications as well as implications for the family as well. So there are certain guidelines for who should be screened for breast cancer susceptibility genes, and the main criteria for screening patients mostly would be people with a personal history of breast cancer at the age of less than or equal to 50 years of age, so they're relatively young people. Certain histology, meaning the type of breast cancer that the person has. So for people with triple-negative breast cancer, some of those breast cancers can be associated with mutations in a couple of genes. BRCA1 in particular comes to mind because of the Angelina Jolie story. People with multiple breast cancers, so again, if you have multiple breast cancers either at the same time or separated in time, that may point to that there's an underlying genetic mutation that may have predisposed the person to getting breast cancer. Lobular breast cancer, which is a less common type of breast cancer, but also with a family history of gastric cancer, because there is a particular gene that predisposes people to getting stomach cancer and breast cancer. As I said earlier, men are unlikely to get breast cancer. So when we see a man with breast cancer, then we have to think whether there is a potential genetic predisposition to breast cancer. Someone with breast cancer and a close relative with breast cancer or other cancers that we can see in some of the breast cancer syndromes, such as ovarian cancer, pancreas cancer, those people may also be candidates for testing. Patients who have multiple family members with breast, ovarian, prostate cancer on the same side of the family, those would be people to go for testing. In terms of people who don't have cancer, if they have a family history of cancer, especially if they have a first or second degree relative who meets the criteria for testing, or if they know that the first or second degree relative already has one of those genes, such as Angelina Jolie, her mother had a BRCA1 mutation. So those would also be people who go for testing. There are various mathematical models out there as well to try to estimate someone's probability of getting or having BRCA1 or 2 mutations. So again, if you meet a certain threshold, you could be a candidate for testing. Again, I want to emphasize that the testing is tightly regulated and you should go to an accredited center for the testing. Some people may be surfing the internet and you see all those direct-to-consumer genetics testing. And the Ministry of Health, as far as I know, they have advised people to exercise some caution in trying to utilize those platforms, because you don't know about the reliability, the interpretation, the privacy involved in those direct-to-consumer testing outside of the framework that the Ministry of Health has set up. Yeah.
You're right, Dr. Chia. I actually got targeted on my social media for this and that. But I, of course, know that my common sense tells me that perhaps maybe I should be a little bit more cautious. On that note, I was advised by my doctor to go and get a gene test. And so I said, why not? I was also thinking, what are the risks for a gene test? Could you talk us through that?
Yeah, so there are certain potential fault from the genetics testing that people may not consider when they say, oh well, let's go for the test. Right? So if the test comes back negative, it doesn't mean that you do not have a gene that may predispose you to breast cancer. It just tells you that you don't have a gene that we know of that would predispose you to getting breast cancer. All right. On the other hand, the testing could come back with a positive finding, meaning that the person is found to be a carrier of a genetic mutation that increases the risk of getting cancer. And that is actually can be psychologically very devastating to people, especially someone who's young, someone who's contemplating having children, and being told that they have a genetic mutation that they can pass on to their family members or to their offspring. And this is at the prime of life when people are planning families and all that. It could be devastating. This again something that when people go for genetic testing, it has to be in the center so that there's the appropriate support when the test comes back with positive results. And of course, there's also the implication for the family members as well. So if your sister were to find out that she has a BRCA1 mutation, then the next thing you would be thinking is, well, I could be affected too. I'm from the same family. I could have inherited the gene as well. So there's also a psychological impact on the rest of the family. Apart from that, some of the gene mutations carry a higher risk of other cancers. So for example, people with BRCA1 or BRCA2 mutations, they may have a higher risk of getting ovarian cancer. Then all of a sudden, people have to start thinking about other strategies like risk-reducing surgeries to remove their ovaries. There's a whole lot of downstream implications of the test results either being positive or negative. And the other part, of course, is more of a financial and insurance implications. So once you know that you have a BRCA1 mutation, for example, if you try to get insurance, it's something that you have to declare, and insurers may or may not look favorably on that. Yeah, so that may also affect their family members as well. So before the testing, usually clients will have to go through all the counseling about pros and cons and potential implications of the outcomes before we proceed.
Yeah, I really see all that happening to me, and the thought processes you had literally brought it to light. That's something for us to all think about, right? I mean, it's something, an information that we should perhaps know as well. I see and I believe most ladies will fall back on monthly breast self-examination and mammograms to screen for breast cancer, aside from genetic testing. Dr. Amanda, we have always heard that mammogram results are the gold standard for breast cancer screening, right? Can you talk us through the process and how difficult how different it is from ultrasounds? How different is mammograms different from ultrasounds?
Sure. So mammograms do indeed play a key role in the breast cancer screening. So they can detect breast cancer before it causes signs and symptoms. So here's how mammogram is typically performed. So you will need to undress from the waist up and wear a gown provided by the facility. After, you will just stand in front of the X-ray machine designed for the mammogram, and the technologists will then position your breast in between two plastic plates, right, on one of which will be pressed down to flatten the breast tissue. I know that some women may experience slight discomfort during the compression, but not to worry if any, it only lasts for a few seconds. And this compression is necessary for obtaining clear images and also to reduce a radiation dose. So after that, 2 images of each breast will be taken, so one from top to bottom and the other one from side to side, right? So the entire process will then be repeated for the other breast. So it takes about 20 minutes for a mammogram to be performed. So on the other hand, breast ultrasound is usually performed with you lying down on a couch. So a water-based gel will be applied to your breast and a transducer will then be used to scan the breast. So there is no radiation involved for ultrasound. So from my descriptions, you may think that undergoing an ultrasound is more comfortable than undergoing a mammogram, and you are not wrong. However, there are reasons why we use mammograms as the screening tool rather than ultrasound. Okay, so firstly, some early signs of breast cancer, such as calcifications, are often only seen on mammogram. And secondly, studies have shown that screening with ultrasound alone results in more false positive compared to mammogram and may lead to unnecessary biopsies. So having said that, ultrasound does play a supportive role in the screening and diagnosis of breast cancer, but it's not used in isolation. And mammograms remains the first line of modality of choice for screening.
Dr. Amanda, I really liked it that you actually walked me through all of it, and in my head, I can actually see that happening for me. So now that I am mentally prepared, could you share with us how can we better prepare for mammogram screening itself?
So great. So the first step of you stepping out and to do the mammogram is the best first step that anyone take, all right? So there are 5 tips that I can share with everyone out there that can help to prepare for the mammogram. So number 1, choose the right timing. So try to schedule a mammogram if possible when your breasts are less likely to be tender. It may be different for everybody, but it's typically during the first week of your menstrual cycle if you are premenopausal. All right. Tip number 2, inform the technologist. So let the mammographer know that if you have any breast implants or breast-related symptoms, especially special considerations may be needed. And tip number 3, all right, so this is quite important. So avoid using deodorant on the day of your mammogram. So don't use deodorant or like antiperspirant lotion or talcum powder on your underarms and breasts on the day of your mammogram, and these products can interfere with the imaging. So tip number 4, dress comfortably. Okay, if you can, try to wear a 2-piece outfit that is easy to remove, as you will need to undress from the waist up for the mammogram. Avoid wearing dresses or 1-piece outfits. And tip number 5, so bring relevant information. If you have previous mammograms, bring them with you, especially if you had it done in a private institution or anywhere else in the world. Right? So this can help the radiologist to compare the images for any changes over time. But all in all, so don't hesitate to ask any questions or express any concerns that you may have about the procedures, as the technologists and the medical staff are there to support you and address your concerns.
Thanks, Dr. Amanda. What I heard was actually do not wear a dress and wear 2 pieces.
Sorry.
I am very well prepared and bring a file with me if I do have some records. But I think what I would like to know, which I did not know before and would like the audience to actually know and share about this, is that are there limitations to mammogram testing?
For sure. Right. So there's no single test or investigation that is perfect. And there are certainly limitations to mammogram screening. So for example, okay, so the sensitivity of screening mammogram is reduced in women with dense breasts. So this is quite a popular campaign that some Americans are saying that because of their dense breasts, therefore the screening mammogram is reduced in the sensitivity. And the other thing is some early breast cancer in the extreme periphery of the breast may not be included in the field of examination and thus may not be detected on mammogram. Therefore, mammogram screening should always be coupled with regular breast self-examinations. And for individuals with high risk of developing breast cancer, like those with a genetics predisposition, your doctor may have to recommend additional screening modalities. Yeah, but having said that, so mammography has been shown to be the first line and effective screening modality in reducing mortality. Then in terms of false positive, so sometimes women may be recalled for further investigation to evaluate an apparent abnormality that is detected on screening mammogram, which may turn out to simply be just a prominent breast tissue, and this is what we call false positive. Some women may get a little bit anxious when they receive a letter to go for further investigation, but nonetheless, this should not deter anyone from attending their routine breast screen, right? And it's always better to get checked early rather than waiting until it is too late.
Thank you, Dr. Amanda. So today we actually do have genetic testing, ultrasound, mammogram. That's a lot of information and data. I think one of the things that I'd like to also ask would be over to you, Dr. Celene, is, we have so many questions that we have as a patient. And I'm sure you, Dr. Celene, would have received so many of such far and varied types of questions. So apart from breast cancer, are there other breast conditions that is also picked up through mammograms?
Yes, definitely. I think, as I want to re-emphasize what Dr. Amanda has said, mammogram is currently the only screening tool that has been proven to save lives. And each mammogram or ultrasound or screening tool should really be used as in the most appropriate setting. One thing I also want to highlight is that there are some patients that commonly come to me and they're very used to tumor marker screening, ultrasound, MRI screening that come in packages from their company or screening packages they've applied for. And they find it hard to move on to mammogram screening. So what we're doing here today is to really explain to you why each modality is different and why mammogram screening is the way to go to detect early breast cancer. I also want to highlight that there are no tumor markers for breast cancer at this point of time, so that's not necessary for breast cancer screening. Other breast conditions that can be picked up on mammogram include benign, which is non-cancerous, usual and atypical or abnormal changes. If an atypical or non-typical change is picked up on biopsy after a mammogram, this actually helps us risk stratify, means put our patients in different risk categories for different screening recommendations. A common example is a condition called ADH or atypical ductal hyperplasia. This means that some breast cells have already started showing some non-typical changes, non-usual changes. This puts the woman at higher risk of breast cancer than her counterpart, somebody of the same age and the same other risk factors. So we tend to keep these patients in our tertiary hospitals and a specialist clinic to be on follow-up, on closer follow-up and inspection because her risk of breast cancer is slightly higher. So if they don't have anything like this, they'll be discharged to breast cancer screening in our Breast Screen Singapore program.
So I think what comes to mind as you were speaking, Dr. Celene, is like when I do breast self-examinations or when we actually have social gatherings, my friends and I would chat, about girly stuff, right? Are the lumps cancerous? That question can be directed to you, Dr. Celene.
Well, so that's a really good question. Thankfully, majority of lumps are actually not cancerous. However, if you do feel a persistent lump, by persistence, I mean a lump that is there today, tomorrow, and even next week, you should definitely see a medical practitioner to get a clinical examination. Breast cancer lumps tend to present as small, big, hard or soft lumps. There's no real one-size-fit-all kind of description, but you should let a doctor have a look at it and take a thorough examination and thorough history taking from you to determine what the next steps need to be. I also want to highlight that most breast cancer lumps are actually not painful, and this is why we see patients presenting very late, because compared to other types of diseases, when we have a stomach ache, when we have a headache, it points to something more sinister. But for breast cancer, it's actually opposite. The breast cancer lumps are generally not painful.
That is so true, Dr. Celene. I actually did not even discover while doing my own self-examinations. I did only see something, but there was a little lump at my chest. And it wasn't even something that I touched. It was something that I could see. So I thought to myself that, for me, as a breast cancer survivor, I would like to share that the initial phase when I was, prior to being diagnosed, I was actually thinking that I'm too young to have cancer. Why did I not know? Why was I not hardworking enough, to get screened? Even though I've not reached the required age, but I did not even have the knowledge. Where we have our corporate events in the office and, different companies would come, we can sign up for this and that. And I did and did not sign up for some, but at that time, I was thinking that such a diagnosis was literally doomsday. And one of my initial thoughts were, will I die? Will I survive this? What if I become botak? And of course, my career. So, Dr. Chia, I believe some of your patients actually do have a long list, longer than mine, perhaps maybe shorter than mine, but a long list of concerns and worries when they are first diagnosed. What are some of the common concerns that people have? Could you share with us?
Sure. So as medical oncologists, we usually actually see the patients of the breast surgeons have broken the bad news. So by the time they come to us, they have had a little bit of time to get past the initial shock, but they also have a bit of time to come up with questions as well. Right. So the questions that you raised earlier, some of the common questions. The first one is, will I die? And for many patients with breast cancers, they actually may recover from their breast cancers. Even for people with metastatic breast cancer, meaning breast cancer that has spread, the prognosis or the outlook and the survival from breast cancer has improved over the last few decades, so that people are living longer with breast cancers. And some people can live for years. So even if they have stage 4, meaning the breast cancer has spread somewhere else, the prognosis and the lifespan may actually still be quite long. So it's important for patients to know that, because it's not doomsday, I'm going to die tomorrow kind of situation. So when we see them for their initial visit, they have, for the patients who have breast cancers that can potentially be cured, they will have spoken to their surgeons about surgery. Some of them may have already gone for their surgery, and they usually have a generous sense of the overall care plan. So when they come to see us, their concerns mainly relate to treatment toxicities from the chemotherapy and how to cope with the toxicities. And usually we'll go through the potential side effects of chemo, the scheduling of chemo with our patients. What I also want to emphasize to people out there is that chemotherapy is also quite different from what it was decades ago. We have better drugs for supporting patients through chemotherapy, better drugs for nausea, vomiting, better drugs for supporting their blood counts during chemotherapy. And so hopefully most of our patients are actually able to go through their chemotherapy with close monitoring.
Different types of worries come from different points of view. So I'd like to turn this over to Dr. Celene Ng Xin Yi. So from your point of view, what are some of the common worries that you also hear from patients, that you are in touch with patients at various stages, right, of their cancer journey? So I'm sure you hear different points of views. Could you share with us? Maybe we start with Xin Yi first.
Yeah, so there are a variety of challenges faced by patients depending on the extent of the cancer and its treatment. Most of the common worries that I hear is actually that patients are worried that they cannot go back to their day-to-day role. Their fear of not being able to do what they used to enjoy, and as well as whether their shoulder pain and arm swelling will worsen. Some of my breast cancer patients actually are worried that they are not able to go back to performing housework, because they are concerned that their spouses or children who is helping them with their housework are not as meticulous as them.
Meticulous. Oh gosh. Those are worries that sometimes we put on ourselves, right?
Yeah.
Okay, what about Dr. Celene, your point of view?
Just to echo what Xin Yi said, that is actually really true. Besides prognosis and survival, our patients are actually usually very concerned about cost of treatment and their ability to return to work. We worked with an anthropologist once, because when I first started in my breast cancer surgery training, it was alarming to me that a lot of patients presented very late, and we wanted to understand from the patient's point of view, why were they coming in so late, even though they knew probably something was wrong. And what we found was that a lot of people, a lot of women hold multiple roles. That's the truth. And they're very preoccupied looking after other people to be able to refocus on themselves and what they need to. Their mothers, their daughters, their friends, their financiers like yourself, meant that all their concerns really revolve around their ability to go back to performing these roles. How much will it cost? Can I return to household chores, just like Cindy said? Can I go back to looking after the grandchildren when my own children are working? What will my children do without me? If I don't cook for the family, will they starve? And this is a very common thing that my patients tell me, like, I need to cook for the family. They won't have food otherwise, you know. I just found a job, will I lose my job? So they also worry, you know, that the treatment will actually cause more harm than good, given that most of these cancerous lumps, like I alluded to before, was, you know, they're not painful. And if they go for screening, they're actually well patients who have just presented for screening and suddenly been given this shocking diagnosis. But I just want to emphasize that breast cancer treatment is so common and very, very good now that they can actually return to all these multiple roles.
So true, right? I think every concern is actually very valid, no matter how big or small they are. And for me personally, I was very concerned about things that were in this way, right? Do I have the best treatment plan? I guess all these thoughts were, is that the best data that I've got? Are my lab results accurate? Is the diagnosis correct? I trust my doctors, but I do have my own thoughts as well. Will I be able to survive this? It's very existential kind of questions I really was that was going through my mind. I trusted the various doctors that I have, but I think common sense and due diligence were some of the things that I wanted to make sure that I do for myself. So instead of just waiting around, I actually proactively went to get my first diagnosis, my second results, third opinion, and I wanted to speak to professionals. Of course, I also have the support from my family. The concerns that I had also included things like, what are the side effects? Will I be vomiting? So just to share a little bit on the side note is that the very first time before I actually had my, so I really did agree to the treatment plan because it made sense. The various doctors that I spoke to actually gave very similar treatment outcomes. So my first experience prior to my first chemotherapy, which was just 2 days later, I actually sat at the cafe 2 hours prior, and still I was late for my first chemotherapy session because I was that nervous. I had to be there so much earlier because I was thinking if the side effects would be very bad for me. But it actually all turned out very, very positively for me, and I had a comfortable experience. So the research that I did also added on some anxiety. So some of the things that I actually were thinking about prior to going to the first session was how much perhaps maybe information that I did not need that I had read online. And the side effects that Dr. Chia and Dr. Celene had shared were also some of the things that I was thinking about. So could you share a little bit more, Dr. Celene, if every patient is given the opportunity to choose their preferred treatment plan?
So yes, of course. You know, at the end of the day, as doctors, we try to cure when we can. Okay, we have this saying that we cure rarely, but then we comfort always. And we really try our best to have an open conversation. For me, when I first meet a patient and diagnosed with cancer, I would always like to have an open conversation to see what actually matters to the patient. I can't assume that the patient is just like me, that our priorities are aligned. And I think that's an important conversation to have with your doctors and to be as honest as possible. And I wanted to highlight that there are actually many different types of cancer. So sometimes patients Google online. That is the commonest source of information. But on top of that, they also speak to their friends or other cancer survivors. But because there's so many different types of breast cancer, some treatment options may be offered to one patient, but not to another. What guides me is the principle of best outcomes, best cancer care and best outcomes. And so I believe that breast cancer treatment should be individualized. If you look at the slides, there are a whole myriad of different types of treatments, and we all work together, Dr. Chia, myself, the radiologist, our physiotherapist. We have to work together to provide the best care for our patients. So generally, you can divide cancer care into 2 broad categories. The first being local regional therapy. If you go to the next slide, you will see that this involves surgery and radiotherapy. Over here, I've also included to show you that actually all of these treatments are mainly outpatient. Toxicities are very well controlled now, and most patients continue working during or after the surgery and the radiotherapy. So local therapy means it targets just the breast and the axilla or the armpit area. Next, we have the other broad group, which is the systemic therapy. If you go to the next slide, you can see that we have chemotherapy, targeted therapy or immunotherapy, and endocrine or hormone therapy that Dr. Chia was talking about. Systemic means it enters the bloodstream to reach all of the organs in the body, as well as some cancer cells that are already inside the bloodstream. I guess overall, it can be said that surgery is like the cornerstone of curative treatment of breast cancer, since the breast cancer has to be removed from the body eventually. The other treatments can be given prior to, we call this neoadjuvant therapy, or after, which is called adjuvant therapy. And they serve to try and decrease the risk of recurrence, as well as to mop up all the cancer cells that are already in the blood and the lymphatic networks. We work in multidisciplinary teams, and we often discuss every single patient that we see. This is very important because when there are other disciplines there, they update us of what are the new current guidelines, current therapies that are available that we may or may not have been aware of. This helps us discuss ahead of time what is the best treatment and makes sure that everybody is kept in check to only provide the best treatment for our patients.
This is like teams working together, which is extremely important for the patient because you actually are so well supported by medical professionals. And over to you, Dr. Chia. What about you? What's your take on that?
So as Dr. Celene mentioned, at all the hospitals, we work as a team. So the multidisciplinary care of breast cancer is not just at particular institutions, but it's quite widespread. So we usually hold weekly meetings and discuss the patient cases and decide what's the best plan of care for each individual patient. So patients may not actually know that because it's sort of behind the scenes, but we do discuss as a group and decide as a group as the best outcome. So you're incorporating a lot of knowledge and expertise across different disciplines as well. So for systemic therapy of breast cancer, as Dr. Celene mentioned earlier, there are all sorts of different options. You may have heard of the hormone therapy tablets, people getting chemotherapy, immunotherapy, targeted therapy. But breast cancer systemic therapy is actually quite individualized, and the treatment options actually depend on how advanced the cancer is and also on what we call the biomarkers, meaning what is sitting on your cancer cells. So there are a few things that we check. One is the estrogen receptor, the other one is the progesterone receptor. Estrogen and progesterone are female sex hormones, and certain breast cancers express receptors for estrogen and progesterone. So what you can imagine is that for some of those cancers, female sex hormones can drive the growth of the cancer. And if you have some way of lowering the female sex hormones or blocking their action on cancer cells, you may be able to control the cancer, eliminate some of the cancer cells, and hopefully improve the survival from cancer. So for women who have what we call the hormone receptor positive breast cancers, they can actually receive hormonal therapy, which is not the same as the hormone replacement therapy, but the therapy to try to decrease the effects of female sex hormones on stimulating cancer cells. There's another marker that we check in breast cancer, which is called HER2. HER2 is actually not very commonly positive in breast cancer. So probably about 20% of all breast cancers are HER2 positive. The majority of breast cancers are estrogen receptor positive and HER2 negative. And the smallest proportion is the triple negative breast cancers, which is only about 10 to 15%. By triple negative, it means that they do not have receptors, the three receptors that we mentioned. So for the HER2 positive breast cancers, the systemic therapy options have really expanded over the last couple of decades. So it's not so long ago, probably about 2 decades ago, that we have our first targeted therapy for HER2 positive breast cancer, which has improved the survival. But since then, we have so many other new drugs coming in that have now turned HER2 positive breast cancer from one that has a not so good prognosis to one of the better types of breast cancers. So the survival has really improved significantly with the new drugs that we have. So for the patients with the ER positive HER2 negative breast cancers, which is the biggest group of patients, the treatment options usually would include the endocrine therapy or the hormone therapy, and some patients may require chemotherapy. For the people with the HER2 positive breast cancers, it's usually some chemotherapy with the HER2 targeted therapies that we have nowadays. And for the triple negative breast cancers, usually it's chemotherapy. But for some patients nowadays, we also have immunotherapy, which is a whole different concept to cancer treatment. Rather than using a sledgehammer to kill dividing cells, you try to activate the person's immune system to help fight breast cancer. So for some of the patients with triple negative breast cancer, immunotherapy is also a rather new and exciting modality available. So patients with stage 4 breast cancer, meaning breast cancer that has spread to the distant organs, are usually not curable from the cancer standpoint. But not curable does not mean that I'm going to die tomorrow, right? So a lot of times when people hear incurable breast cancer stage 4, the doomsday thought comes to mind. But even though the breast cancer is not curable, for many breast cancer patients, especially the ones who have the ER positive HER2 negative breast cancer or the HER2 positive breast cancers, they may live with their metastatic breast cancer for many, many years with with good control of their disease and good quality of life. So usually the mainstay of treatment would be systemic therapy because the cancer has already spread. In some cases, on a case-by-case basis, there may be also a role for palliative surgery or palliative radiotherapy. So if they have a breast mass that's causing them a lot of symptoms, the surgeons may go in and take out the breast mass and improve their quality of life. Or if they have a particularly painful area in the bone, the radiotherapist may be able to try some radiation and target that area for pain control. So overall, the survival from breast cancer, even for stage 4 patients, have improved over the last few decades. Yeah.
There is really a lot of hope, and thank you for sharing that there is so much hope that we can look forward to. And being a triple negative type of cancer that I had, I also had immunotherapy. And my doctors actually did also explain, like yourself did, the different type of options that I have. There's also papers that were backed that supported what the treatment plan options were. With that, I actually realized that I have learned so much from all of you here that I had learned in 12 months, but we're getting it all in this session. So for everyone out there, please share this with others that you will come in touch with. And now I would like to also bring our attention back to Dr. Celene. Dr. Celene, just now you mentioned that doctors always comfort first. That is really very comforting to actually know and to hear that, that actually our emotions and our mental state of health is also very important on top of the medical care that we have. So for me, I actually did have a mastectomy, which was the surgery of my breast, and I took the construction from my abdomen, and that is actually called the flap. So Dr. Celene, you do some of that as well. Could you share with us, is mastectomy a better option? I mean, to remove like one breast, right? Or in the case of actually having to change our body image as a female to reduce the risk of a relapse? Now, this is a very, very important question. And I would like to know if there is a difference between a late stage and an early stage diagnosis.
It is a very, very common and a common misconception, I would say, that a lot of patients have. They sometimes come away thinking that if they do breast conserving surgery or they do a lumpectomy, their outcomes will be poorer. But it's been already proven for decades, not just 1 or 2 years, decades we're talking about, that breast conserving surgery or lumpectomy as patients know it, with the addition of radiotherapy, has been proven to be equivalent in outcomes to mastectomy. And patients, I believe, should really be offered a choice of surgery when available. In fact, recent data also seems to point that radiation on top of a lumpectomy actually may have better local recurrence outcomes, but more data is needed for conclusions to be made on that topic. In general, surgical risk is directly correlated to the amount of surgical trauma induced. So if you think about it very simplistically, if less is removed, then there is less surgical trauma and less risk. Like I said, it's an oversimplification, and there are other technical and patient factors to play a role. Stage is generally directly correlated with size. So you can imagine that with later stage cancer in general, the dissection and the surgical trauma tend to be more. And in very, very advanced cases, we see the muscles and the ribs may be involved and have to be removed, and tissue will be borrowed from other parts of the body to reconstruct this area. However, I want to emphasize that size alone is not the only determinant for stage. So there are patients who have much larger cancers, but are actually at a lower stage because it hasn't gone into the lymph nodes, for example, and are still able to preserve their breast. As we know, breast cancer first spreads from the breast and then to the armpit area. We call these lymph nodes in the armpit area, and then to the distant organs. As part of staging, lymph node testing is also done. This is called sentinel lymph node biopsy, and it has to be performed. In general, we remove 1 or 2 nodes for testings, and if the lymph node is involved, we remove the rest of the lymph nodes. Now, the risk of blockage to the tracts or the lymphatic tracts results in lymphedema or swelling of the arm. And this can result in repeat infections, loss of function in severe cases. However, if you leave the cancer there, It also results in blockage of the lymphatics, and then your arm also renders, not useful or repeated infection. So to me, another important part of diagnosing cancer early is to try and avoid lymphatic or axillary surgery, actually, not just the breast surgery component, because we have many different ways now to help you preserve your breast.
Wow, I actually had a few of my lymph nodes taken for sampling, and the results were actually given to me. So I think, with all that surgery, I actually had a few different experiences, right? And one of the things that I really appreciated during my journey was actually having a physiotherapist. It was like another good part of a journey, because it helped me to finish and complete the race. And so, Xin Yi, I understand that you work mainly with breast cancer patients undergoing rehabilitation. Are there side effects that are commonly seen in breast cancer patients? Because personally, I had such side effects, which are like, for example, I could only raise my arm 20 degrees after my surgery of a mastectomy with the diap flap from the abdomen. I actually felt like everywhere was tight, right? Like my chest, my arm, my torso. Basically, it was difficult, of course, initially to sit up, to walk. But my doctors actually said, nope, you're not doing that. You're going to stand up and do your thing on the second day onwards. So I practically had only one day on my bum, and the rest of it was physiotherapist that helped me right in the hospital. So that really woke me up, right? Because the experience was like, ouch, ouch, ouch. And it was really worth it, because without that good discipline, which I had from day 2, I would not actually be able to rock climb, do all kinds of strength training and different kind of sports, like, for example, I don't know, like, for example, but I'm thinking bungee jumping, but no, I just did bungee fitness. So that was fun as well. But all kinds of big movements with my body that I can make sure that my muscles, my tissues, like Dr. Celene said, are working well together. So from your point of view, Xin Yi, could you share with us what are some of the commonly seen side effects in cancer patients?
So some common cancer and its treatment-related side effects are musculoskeletal pain, weakness and the tightness of the affected shoulder and arm and the chest area, like you said, due to the surgery. And as Dr. Celene said, lymphedema. Lymphedema is actually abnormal swelling of the arm due to the removal of lymph nodes and damage to the lymph nodes due to radiation therapy. Patients also face decrease in muscle strength and endurance and increased fatigue after treatment, which is actually very common for breast cancer survivors.
Are there any things that patients with lymphedema should take note of? I mean, I hear some of my friends say that, should I exercise? Should I travel? Actually, I don't really know how to answer them. Could you shed some light on that?
So depending on the extent of arm swelling, patients with active arm swelling should ideally wear compression arm sleeve prescribed by their certified lymphedema practitioner. So as a rule of thumb, to put it on before the flight and to wear it throughout the flight. So for patients who do not have active arm swelling but are at risk of lymphedema due to the extensive removal of the lymph nodes or damage to the lymph nodes because of radiation therapy, the certified lymphedema practitioner usually provide more of education for them to understand the potential risk of developing lymphedema and how they should go about managing the situation should there be a sudden arm heaviness or swelling. Now, pertaining to exercise, research has actually shown that a structured and safe exercise regime is important to help to manage arm swelling. Building of strong muscles actually helps to increase the movement of our lymphatic fluid through available channels and also maintains and improves the strength and the flexibility of the swollen region. However, for patients with controlled arm swelling, the weights that they are carrying should be gradually built up over time to prevent sudden increase in arm swelling. For example, when they are using dumbbells, they should start off with a lowest weight, 0.5 kg, and then with fewer repetitions, such as 2 to 3 sets of 8 repetitions each. Then from there, they slowly progress up by increasing the number of repetitions and sets before increasing the weight of the dumbbells. It is best also to consult a certified lymphedema practitioner before starting any exercise program. Patients should also monitor their affected arm during and after exercise for any change in the size, the tissue, shape, soreness, heaviness, or firmness, because this might indicate a worsening or development of lymphedema.
Cindy, when you said about dumbbells and weight training, right? I felt really bad about myself initially when I could not even pick, like for example, my laptop up from a lower point. And here we are talking about heavier weights, right? I think that realistic expectation of having our body adjust over time is also very important. And I got that knowledge actually from my physiotherapist. And one of the virtues that I am reminded to have is patience. To actually be very patient with our physical recovery, which is going to take time, and it will only recover over a period of time. And with that, I also heard that you said we actually should get our arm sleeves from a practitioner that is certified. So that is something to also take note of as well. And on this note of recovery, surgery, chemotherapy, both treatment options are very, very beneficial with its side effects, which are widely feared and also experienced by many patients and caregivers or friends who have heard of as well. So my question to Dr. Chia now would be, are these side effects actually blown out of proportion?
I think everyone, when they hear chemo, the first question is, am I going to die from this? It's really toxic. They have a picture of people losing their hair completely, having very severe nausea, vomiting, not being able to eat anything, and feeling so weak that they are bedbound. So I think chemotherapy affects individuals very differently. Okay, so some people may have very few side effects. Some people have a lot. It's a bit hard to predict who will have what degree of side effects. But and before anyone starts chemo, there is great fear because we do counsel them about the potential side effects of chemotherapy. Not so much as to scare them, but we have to let people know what are potentially serious side effects that they need to seek medical attention for promptly. Doesn't mean that it will happen to them. So we'll always emphasize to them that we tell you have to come in because of fever, we tell you have to come in because of severe nausea, vomiting, diarrhea, and all that. It's not because it will happen to you, but because those are serious things that may be that may need prompt medical attention. But unfortunately, when we have that discussion, people hear that and sticks to their mind that they are going to have fever, severe nausea, vomiting, diarrhea, their hands will go numb, their hair will fall out. So people become very stressed. And therefore, a lot of times when people first come in for their chemotherapy, we also have our nurses sit with them and talk with them about what to expect, and also our pharmacists as well. So generally speaking, some of the drugs that we have to support patients through chemotherapy are better nowadays. So it's not just improvement in the chemotherapy drugs that we give people, but also the supportive medications. So we have better drugs for decreasing nausea and vomiting. We have better drugs for supporting people's blood counts. So by and large, most patients actually are able to get through their chemotherapy. Most people do not get admitted to the hospital from complications of their chemotherapy, and it would be terribly unusual for someone to die from chemotherapy. So I just want to make that clear to people. People may have some side effects, nausea, no vomiting, still manageable, and by and large, the side effects can be manageable. We also see patients before each chemotherapy cycle, and if people have a lot of side effects, or if their blood counts are not good, their blood tests are not good, we may make the adjustments to their schedule, either to delay the chemotherapy a bit, or we may cut down the dosage of the chemotherapy a bit to try to get people through chemotherapy. And for our center, we also have a phone support system with our nurses called the Cancer Care Line, whereby patients who are experiencing chemotherapy side effects, they're not quite sure what to do about their various side effects, they can call and speak to an oncology nurse for advice. So we try our best to support people through side effects. There are some people who will have serious side effects, but by and large, many patients do quite okay with chemotherapy with manageable side effects.
Actually, Dr. Chia, you had shared a point of view from different center from the one that I had gone to, but the experience is actually still very similar as what you had described. I had very good support. I also had very personalized attention, like you had mentioned. And whenever I needed to, I could always reach out to someone. I think the best thing for me that was most comforting was actually knowing that my doctors worked with other doctors to make sure that I was getting the treatments that I needed. And when there were some delays that were required, I also too had a little bit of like 2 or 3 kind of days to monitor the situation before the treatment continued. And it's true with the side effects also that there are very varied side effects which are very different for everybody. So for me, I had the better side effects, which was I actually, instead of vomiting, I had too much to eat because I was practically hungry all the time. You know, the other side effects that I felt was a lot of fatigue. So I think it's very different for everybody, but like you rightly put, it's very mild for the treatment options that we have in Singapore because we have such a great support system here. So as women, you know, I believe that the greatest fear at the sort of surgery is the outlook of breasts after treatment, right? How do we look at ourselves? So Dr. Celene, is it common for patients to opt for breast reconstruction in Singapore? And when do we actually start having this conversation with our doctors?
I'm glad that you brought that up, Julianne. I think when we see a patient for disclosure of diagnosis, sometimes the shock of the diagnosis, especially because we are the first ones to tell it to them, can be a lot, okay? And then supportive family members or friends who come with them, well-meaning as they are, they will say, you know, I love you, just take it off, I will still love you, I just want you to be with me. And they definitely say it in love, in care and in concern, but sometimes this may leave the patient unable to really share how they feel and what else they're thinking about. And sometimes they may feel, oh, it's very frivolous for me to ask my doctor, I just want to keep my breasts, but I don't care about my life. We know that they don't mean that. We know that they mean they want to live a good life after their cancer diagnosis and their treatment. So I try to ensure that I explore all available options with them, and they see our breast care nurse, just like the cancer nurse that Dr. Chia talked about, where they can see photographs beforehand so that they know what to expect. I also sometimes try to encourage them to take 1 or 2 days or even a week to consider what they really want. And if some patients who are going through mastectomies because they've opted for it or because they want to, I tell them to even say things like, look in the mirror and say bye-bye to the breast physically, because every day you are looking at yourself when you're alone. When you're clothed, when you're with people, it's easy to kind of forget about that. But when you're alone, that's when all the emotions come in for our patients. Having said that, I think if patients require a mastectomy because of the extent of disease, or if they opt to, I believe that they should be offered immediate reconstruction if available, and that's what you had, Julianne, and when it's suitable. If the patients find it very overwhelming at this point of time, they can also consider delayed reconstruction. After all the cancer treatment is done, they are stable and on follow-up for 1 or 2 years, they can always consider this option later on as well. That being said, some patients may not be medically fit, and we have to understand and respect that every individual is different. So I do have some patients who are equally happy after having a mastectomy, whether or not they were offered other options. I believe that the discussion should start as early as possible, because systemic therapy given by the medical oncologist may be sequenced prior to surgery to help downsize the cancer for potential breast conserving surgery if that's important to our patients. And proper planning really enables us to offer the patients much more options. For example, patients with larger tumors or larger, we call tumor to breast size ratio. So the tumor is maybe 2 to 3 cm, but then the breast size is slightly more modest. We are also able to offer breast conserving surgery using more complex techniques called oncoplastic techniques that are also very safe for the patient, or we can use chemotherapy, hormone therapy to try and downsize the tumor first. I prepared some slides just to describe this. If we move on to the next few slides. So on the top left, you can see a conventional mastectomy where on one side, the patient has a flat chest. You can easily wear prostheses in a bra, similar to a bra padding, and this helps them look pretty indistinguishable to other patients in clothes. Next to it, you can see various scars. It's a bit light here, but basically we place scars at different cosmetic angles to try and remove part of the breast, but preserve the whole breast as a whole. And below it, you see a simplistic diagram that explains how we can use the tummy fat, sometimes the back fat, to reconstruct a breast, just like what Julianne had. On the next slide, you can see some oncoplastic techniques that are commonly used. To understand this simplistically, basically when we take out more than 30% of the breast tissue, we might need to replace the breast tissue by borrowing tissue from either the side of our breast or just underneath it. These are often day surgeries, meaning that the patients can go home on the same day. And because we're not borrowing tissue from the tummy or the back, we're actually not losing any muscle or any function. The other way is that I sometimes offer my patients to downsize their both breasts. That makes it a tighter, taller breast. And I think if the patient is a suitable candidate, I want to emphasize that every patient is really different. And if they're suitable, then sometimes they find that this is a silver lining to their diagnosis, and this helps comfort them. But the primary care that we need to give needs to focus on the cancer surgery and the oncological outcomes of the surgery. So have an open discussion with your practitioner as soon as possible. And all of us, I'm sure, in a multidisciplinary team, always take note of our patient's psychosocial and sexual health in any of this planning.
Dr. Celene, you know, having options in life is so important, right? And I think having that at our disposal is also equally our right and obligation to ourselves and our families to make that. Every single one of us are very different, and we all have different mindsets, worldviews, and different values. And there is no right and wrong to each of our own. So some of the things that we have heard here, your family members may have experienced as well, and you would have heard them say. So what we want to do is make sure that you have the right information, and on top of that, also understand that our emotional and mental aspects to that, for me as a survivor, are also equally as important as the treatment options. On this note, does breast reconstruction then bring any complications to subsequent mammograms and rehabilitation efforts? Dr. Amanda, would you like to answer that?
Sure. So there will be different imaging modalities that the doctors can recommend, okay, depending on which type of reconstruction that the patient undertakes. For example, for patients who just had an implant, right? So mammogram can still be performed for patients who have implants. So for patients who has undergone a flat reconstruction, so MRI breast can be performed for those patients if needed. And ultrasound remains a useful tool, right, to support any investigation for all the patients, regardless of the type of the breast reconstruction.
Actually, I have just gone for my mammogram and ultrasound, so yes, it's all good. And what about you, Xin Yi, from your point of view, what happens when patients undergo surgery?
So when patients undergo breast reconstruction, the common complication we see during rehabilitation is actually the tightness of the area where the skin graft is taken, for example, the abdomen or the back, causing pain, which actually might result in the difficulty in movement and subsequent weakness of the muscle in that area.
So, Xin Yi, could you share some advice on when and how should breast cancer patients actually seek help on rehabilitation support?
So breast cancer patients actually face many physical and psychosocial challenges during and after their cancer treatments. So first and foremost, cancer warriors, please don't be shy. Being aware of the changes in your physical and mental health is very important. A whole host of issues such as fatigue, reduction in body strength, arm swelling, pain, mood swings, numbness, weight concerns, concentration issues, and intimacy challenges are common across all breast cancer patients. Singapore Cancer Society provides a one-stop rehabilitation services for all cancer survivors. You may reach out to us at our Outram headquarters or Jurong Medical Centre branch. Alternatively, we also work closely with all the main cancer treatments in Singapore. You may connect with your primary cancer care team to seek assistance to be referred to our centre.
Wow, we are coming to an end. So And finally, in a few words, what do each of you hope that our audience here today will remember as one key takeaway, or a few from your sharing today? And advice, encourage, maybe give us some advice or encouragement of, for breast cancer patients out there and their families. Perhaps maybe we can start with Dr. Chia first.
So I want everyone to keep in mind that breast cancer is actually a treatable cancer. So many patients with breast cancer can be cured with multimodality therapy. And even for patients with metastatic breast cancer, many of them are living for years with their cancer with fairly good quality of life. So the prognosis of breast cancer is better when the disease is found earlier. But sadly, in Singapore, we actually still see a fair number of women who present with very large breast tumors. And some of them are bleeding and fungating. So the message to everyone is, if you are of the appropriate demographics, to go for screening. If you are, regardless of your demographics and whether you're suitable for screening or not, if you do find a breast lump, do not ignore it. So while breast cancer usually affects older women, we have had young women being diagnosed with breast cancer after finding a breast lump. And some young women may be so young that they are in their 20s, they are in their late teens, and those are not the people that you would send for screening. But the breast lump should never be ignored. Similarly for the men as well in your life. So if they find a breast lump in the man, that is also something potentially serious and they should seek medical attention. So if by encouraging your loved ones with a breast lump to see a doctor, you may be saving their lives. By encouraging your loved ones to go for screening, you may be saving their lives.
And also the fact that you need not to be of age to get a screening. Please do not be like me and don't procrastinate. Dr. Celene, what is that key takeaway or a few for us?
I think for me, it would be breast cancer does not discriminate. It can affect any of us here today. It's mostly curable and there is life after breast cancer. I think Julianne is a great example of this. We have the chance to catch breast cancer changes at its earliest pre-cancer stage and prevent it from even becoming cancer with just self-breast examinations and mammograms. Treatment of breast cancer at its earliest stage is often just surgery and radiotherapy. For me, I think this is important. It causes as minimal interruption to a patient's life. We all have hopes and dreams and aspirations that we have worked our whole lives towards. And just like you said, when your life was stopped in its track, let's not let cancer ruin that. So show love in a practical way by offering to do the chores, to cover a shift at work, to help take care of a dependent so that women in our lives can take that half day to go for a mammogram. And to our brave survivors like Julianne out there, you really inspire us to work hard every day for a better future for all women.
Dr. Celene, it's so heartening to see all of you female medical professionals here who are actually advocating and raising awareness. I think one thing that every one of us would like to share is that there is actually hope and that there are options to be considered. So what is that key takeaway from your point of view, Dr. Amanda?
Yeah, so the HPB recently told us that the uptake rate of screening in Singapore is at most 40% among the women. So there are 60% women out there that are not going for their screen, right? So hopefully, thank you so much for sharing your personal journey. It definitely, I hope that it gives lots of hope to other people. Okay, so please attend your breast screen and attend it regularly. Don't attend it for one year and next year don't count, and next time you attend it is in 10 years time. Okay, so attend it regularly as early detection saves life. And for the breast cancer fighters out there, so stay strong and stay courageous. Sunrise brings a new day with the new hopes and possibilities. So in times of sadness, please do remember that we are all here to provide you support, and we're all in it together.
I was laughing because I actually am one of those people. Maybe I come this year, next year I don't come, and then I'm gone forever, right? So I don't come back. So I now know that I should not be one of those people or should not have such bad habits. But on another note, physiotherapy was so important for me, and I encourage everyone who has gone through or who knows of some others who are going through, please get yourselves into that physical rehabilitation, because it really helps our tissues, our muscles get back in order. So what is that key takeaway from you, Xin Yi?
So reaching out for help is not a sign of weakness. It's actually a sign of courage, strength, and hope. So if you or anyone you know needs help to manage some of the challenges shared today, do approach us. And remember, you are not alone. We are here for you.
That is so right. We are never alone. Thank you, Dr. Chia, Dr. Celene, Dr. Amanda, and Xin Yi. We have now come to our Q&A segment. So questions that we were thinking of, pop it into our chat board, and we would like to take this time to also thank you for this overwhelmingly great response. But unfortunately, we are not able to answer every question. But we have picked out a few, and we will also continue to monitor for a few more that you would like to ask. So here are the most commonly asked ones that our team has picked out for our doctors today and medical staff. But for now, first, I will answer the one that was perhaps maybe I can answer for people who have gone through breast cancer or will go through breast cancer, or you will know of someone. So the question is, do you have any regrets in your cancer journey? What would I have done differently? Okay, this is a very difficult to answer question because I generally don't like regrets in my life and I tend not to have any. But one thing I would say loosely that I did regret was not eating enough. I was actually, having all the different types of foods that I particularly did not want to have because I wanted to eat clean, right? But I was enjoying it all. But anyway, story for another day. On the other hand, I was also out enjoying the day so much that perhaps maybe my other regret was not sleeping enough in the afternoons. Insomnia kept me up at night, so I generally slept at about 8 p.m., which is a common side effect in insomnia, and will wake about 4 or 5 a.m. So those are my regrets, not sleeping and eating enough. So please do that. So for me, I also am thinking that the second question should actually go to Dr. Chia. Okay, Dr. Chia, how does breast cancer affect a woman's fertility and menopause?
So for some of our younger patients, they are premenopausal and they may be planning their families, they may be at their prime, and unfortunately breast cancer struck. So chemotherapy can affect future fertility. And for the young breast cancer patients who are of childbearing age, generally I would recommend that when you are first diagnosed with breast cancer, when you are told by the surgeons that you have breast cancer, ask them about future fertility because chances are you may need chemotherapy. And usually for fertility preservation, patients will need to be referred to a fertility clinic to discuss the options, which may include harvesting of oocytes before chemotherapy, and that process may take a couple of weeks. So for some of the patients who are planned for chemotherapy, we encourage them to actually speak to their doctors early, get referred early, so that they have the time to go through the fertility treatments as well. So for most young patients who come to us with who are of childbearing age, we do have a discussion about future fertility. Some patients may not be able to get pregnant with the chemotherapy. And so before we start any of the chemotherapy, it would be ideal for patients who really want to have children down the road to be referred to the fertility clinic and for harvesting of oocytes, ovarian tissue and all that to be done before chemotherapy. The likelihood of hitting menopause or cessation of periods after chemotherapy also increases with age. So for women who are in the mid to later 40s, they are pretty close to menopause already. And for those women that chemotherapy may actually bring them into menopause a bit earlier. And for younger women who are in their 30s, they may still resume their menses after chemotherapy, but it's hard to tell for individuals. Generally speaking, the older the person is, the closer to menopause they are, the more likely they will enter menopause from chemotherapy.
Also, I did have a pause in my menstrual cycle during the time of chemotherapy treatments, and it kind of came back about 6 to 9 months later. So everything went back to normal. And this question, I think, would be perhaps maybe for Dr. Amanda. Okay, what are the common misconceptions surrounding mammogram?
So there are two common misconceptions. So the first one is everyone heard that mammogram has radiation, and radiation is so dangerous, it can cause cancer. I don't have any test that has got radiation, right? So I really want to take this opportunity to assure everyone out there that the radiation dose of a screening mammogram is way below the threshold for any safety concern, right? So a typical dose of a screening mammogram is about 0.4 millisieverts, which is equivalent to about 7 to 8 weeks of our normal background radiation dose that we receive in our day-to-day life. And so it is shown that the benefits of receiving a mammogram far outweighs the risk of the radiation exposure. So in fact, mammogram is the single most effective method for early breast cancer, and it can save lives. Okay, and the second common misconception about mammogram is that it is painful. Well, I don't deny that breast compression can be uncomfortable for some, but it only lasts for a few seconds. And those few seconds can be potentially important enough to detect any breast cancer. And so it is definitely within tolerable limits, as millions of women around the world can assure you, and I really hope that you will not let this momentary discomfort deter you from attending breast screening.
I think there are many other scarier things in life. After having gone through mammogram myself, I would say that my experience has been pretty comfortable. So I actually did a 3D mammogram, which if we have time later, perhaps maybe we could discuss what's the difference between a regular mammogram and a 3D mammogram. But for now, I think we do have a higher vote on this question. Are most drugs used to treat breast cancer inside the cancer drug list? So the question is, are most drugs used to treat breast cancer inside the cancer drug list? I think Dr. Chia and Dr. Celene. Maybe we start with Dr. Chia first.
As most people out there are aware, the Ministry of Health actually introduced the cancer drug list in September of 2022. So their rationale was to try to control the costs of cancer care in Singapore. And now there are restrictions on the coverage of cancer drugs, even for patients with integrated shield plans. So in the past, people with integrated shield plans, especially if they have riders, essentially have a blank check with a small amount of copay to get any cancer drug. But since the introduction of the CDL, or the cancer drug list, in September 2022, this has changed. So the insurers can only cover drugs that are in the cancer drug list under their integrated shield plans. For people with riders, the riders may be able to cover drugs that are not on the cancer drug list with varying degrees of coverage. So of course, then the question people would ask is, are the drugs used to treat the breast cancer inside the cancer drug list? If it's not, how are we going to pay for the drugs? So fortunately, many of the drugs that we use to treat breast cancer, in fact, the main ones that we use to treat breast cancer are on the cancer drug list. And many of them are actually subsidized by the government to make it more affordable for Singaporeans and Singaporean PRs. So some of the drugs are now that we use to treat breast cancer are now considered standard drugs, and the cost of, for example, targeted therapy for HER2-positive breast cancer now is covered on the cancer drug list as a standard drug. So the cost has gone down substantially, and it's more affordable to breast cancer patients now. Some of the newer drugs that we use in conjunction with hormonal therapy, for example, for patients with metastatic hormone receptor positive breast cancer, those drugs are now also on the cancer drug list, the CDL, with additional government subsidies to help cover for the cost of those drugs. So overall, most of the drugs that we use to treat breast cancer, the cost-effective and efficacious ones, are on the cancer drug list. There are newer drugs out there that may have shown benefit in clinical studies, but as you can imagine, it takes time for the drugs to be approved by the Health Sciences Authority. But beyond that, to get on the CDL, the drug companies and also physicians and patients can advocate for that. It takes some time for the drugs to be put on CDL. So there will unfortunately be a time lag between a drug being shown to be efficacious and making it to the CDL, so that's more affordable. But we do have a lot of drugs in the past that were not very affordable for many patients now being on the CDL. For example, you had the immunotherapy for your breast cancer. So now for breast cancer patients with triple negative breast cancers, some of the indications that would for which immunotherapy has been shown to be beneficial are now actually on the CDL with additional government subsidies. People who have had immunotherapy before will know that in the past, the drug costs were just substantial, and outside of people having great insurance, people really could not afford it just with the MediShield Life coverage. But now that some of the drugs are on CDL, patients do have access to immunotherapy as well for certain groups of patients with triple negative breast cancer. So there are pros and cons. It has improved the access to certain drugs, but of course, for the newer drugs, there may be a bit of a delay between getting the drug here and on the CDL. Yeah.
You have actually pointed out the most important thing that many cancer patients actually experience, which is financial options that we may need to dig out of our savings, or actually find if we have those insurance policies, or perhaps maybe now have another option, which is to check on this cancer drug list if we actually have what is prescribed and needed for ourselves on this list. Financial situations vary from person to person, but what we are very fortunate of is that we actually do have a very comprehensive list that actually has got most of the treatment drugs in there. So for the different options that we have, we will also like to take and see what other type of questions that we have for Dr. Perhaps, oh, okay, sorry. So I think we do have the same question for Dr. Celene, is it? No, okay. So I think the next most popular question that we have that is highest vote is our common daily life. So from financial situations to drug lists, let's talk about daily life here. What are the hobbies that breast cancer patients and survivors can do or cannot do post-surgery? Xin Yi?
So it actually depends on the extent of surgery. Prior to beginning of any exercise or strenuous sports, ensuring that the wound is fully healed is key. Sometimes the healing takes a bit longer, depending on the patient's unique health conditions and whether there is a need for future radiation therapy. So generally, 6 to 8 weeks after surgery, we will encourage our patients to start off with some light activities and then build up gradually. Now, the rehabilitation specialists work closely with the primary care team, such as the surgeon and the medical oncologist, to ensure patients are safe before embarking on any physical activity. There is no strict restriction on the types of activities one can or cannot do. A rule of thumb is to start slow and gradually build up. For instance, I have a recent breast cancer patient who hoped to return to dragon boating as soon as possible after a mastectomy, axillary lymph node removal, and radiation therapy. Now, given her high-risk profile of acquiring arm swelling, in addition to her arm shoulder pain, I actually advise her to start off with rowing for short bouts of 10 to 15 minutes with interval rest so as to ensure sufficient muscle recovery. Now, this same concept goes to any other hobbies.
It seems like you're speaking in like a language that perhaps maybe only people who are very active can understand. But I'm not so sure I was that person actually before when I had my surgery, because I practically was like feeling fatigued all the time, right? And I didn't want to do anything. So ask me to move, I would rather just stay in bed. So I think I would like to direct the next question. How can I actually reduce the cancer treatment fatigue?
Okay, so first of all, you need to understand that cancer treatment fatigue is actually common. It's not something that is abnormal. It's common due to all the treatments that you have. So how do you reduce? So first and foremost, if you are tired, please do take a rest. And then try to remain as active as you can. if you're not so tired. So you could take a rest, and after that, if you are feeling better, you can go for a short walk. It could just be like a 10 to 15 minutes walk, and then you take a rest again. If you can continue, you continue. So the idea is to be as physically active as you can, and at the same time, do take a rest if you're feeling tired.
I would like to direct the next question over to, perhaps maybe let's look at this question first. How is the regular mammogram different from the 3D mammogram, which I actually did a 3D mammogram? So Dr. Menda, could you share with us what's the difference between a regular and a 3D?
So the technique for acquisition of the image are similar for both the regular and also the 3D. So where your breast will be compressed and the X-ray of the breast will then be taken. But instead of just 4 images like a routine mammogram, a 3D mammogram involves multiple projections that are acquired across an arc. And these are then reconstructed into several images that the radiologist can then read it. So it has a slightly higher radiation dose as compared to a normal mammogram. So as of now, it is commonly used as one of the problem-solving tools in Singapore.
Wow, looks like we have only a few minutes left. So I think that's all the time that we have for today. And I would like to thank you for your attention and your patience, as well as also these wonderful professionals who are the angels along the way, who help us, who help all our family members and our loved ones through the darkest times or challenging ones as well. On behalf of Singapore Cancer Society and our partners, National University Cancer Institute, Singapore Breast Cancer Foundation, National Cancer Centre Singapore, Tan Tock Seng Hospital, and Health Promotion Board, together with our sponsors Gilead, AstraZeneca, and MSD, we would like to thank you for tuning in to our webinar and for actively participating in our questions. We would like to thank our panelists for their time today and their wonderful sharing and their contribution to the society with regards to breast cancer's community. If you wish to rewatch this webinar, and it will be available on Singapore Cancer Society's Facebook page. Remember, you actually will learn so much in this short time here in comparison to gathering the information online or everywhere else. Some additional information happening this October. In the months of October and November, eligible women can receive SCS mammogram funding assistance of $25 at 50 locations island-wide. So to qualify for funding assistance, appointments can be made and must be done so at the participating breast screening centers by 15th November. And the mammogram screening must be done by the 30th November. For SCS Clinic at Bishan, also provides mammogram screenings at no charge all year round. So for women with valid orange-blue CHARS cards, do visit the website of SCS or call 1-800-727-3333 for more information. This year, we have partnered with National Volunteer and Philanthropy Centre for a fundraising campaign on giving.sg, where you can support many breast cancer-related causes. So visit www.giving.sg/BCAM to read more about the various causes and how your